Welcome, everyone, to the Brain Health and Wellness Initiative series. Tonight, our presenter is Dr. Elizabeth O'Toole. She is presenting on strategies to consider in addressing ethical dilemmas in dementia. My name is Courtney Kelly, and along with my colleagues Hannah Doles and Cassie Fazikis, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those who have dementia, who are at risk of developing dementia, while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance in working with our clients' strengths and applying a person-centered approach to care, which extends through our multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Hannah, Cassie, and I meet our clients where they are and develop individualized care plans that help produce solutions to presenting problems. From linking persons with dementia and their families with community resources to following them with their medical management, we are their point of contact for guidance as well as a listening ear. We consider the intersectionality of one's life when creating interventions that adhere to their biopsychosocial needs and experiences. If you need to ask a question during the webinar, please click the Q&A button in the Zoom webinar system at the bottom of your screen. Type your question in the Q&A box and submit it. Please do not submit a question using the chat button. Afterwards, we'll be sending you a short survey, which will be emailed to you after completion of the event. JFSA is pleased to offer continuing education credits. Please note it will take 30 days from the date of your application, that's the completion of the survey, to issue your CE credit. Your CE certificate will be emailed to you at the email address you provide during registration. The email address that you use to access the webinar must be the same as the one you are providing. Entering a different or an incomplete email address will prevent your CE from being issued. If you are unsure of the email you used to attend, please check your original confirmation email. Tonight's presenter is Dr. O'Toole, who graduated from Case Western Reserve University School of Medicine and completed residency in internal medicine with fellowships in general internal medicine, clinical ethics, and geriatric medicine at University Hospitals of Cleveland and Cleveland VAMC. She has been professor of medicine and bioethics at CWRU School of Medicine. I will now turn this over to Dr. O'Toole.
Thank you, Courtney. Hello, everybody. As Courtney said, the title of the presentation is Strategies to Consider in Addressing Ethical Dilemmas in Dementia, which is a really big topic and certainly worth a lot of time thinking about. And so I'm going to be able to talk about a few things in an hour, just to give you some ideas about ways to think about these situations, and then we can, if we have time at the end, we can talk a little bit about that. So the overall goal is to empower thoughtful consideration of these ethical dimensions of decisions that are often occurring in the context of dementia. Next slide, please. The specific objectives are to review some of the basic bioethics principles, which include many things you may be familiar with already: autonomy, beneficence, non-maleficence, justice, and also the principle of double effect. Even though we sometimes intellectually know what these words mean, I'm going to ask you as we talk about them today to think about them in context of actually applying them to decision making or even approaching a situation. The second objective is to try to think through some decisions in some cases and other contexts involving some common events that occur in the dementia journey, including decisions about driving, about managing affairs, especially finances, healthcare decision-making and advanced care planning, and artificial fluids and nutrition, or feeding decisions. Next slide, please. Okay. So back on the bioethics principles. When I first started many years ago in this, these were like critical, almost alphabet to use to talk about ethical issues. And at the time, it was an abstract concept to me, somewhat. But in fact, these are really meaningful ways to think about things as they really occur in real life. So we'll talk a little bit about autonomy, beneficence, non-maleficence, and justice, as I just mentioned. Next, please. And in doing that, we'll talk about driving in terms of safety decisions, finances in terms of managing affairs. We'll talk a little bit about advanced care planning as an element of healthcare decision making and choices about feeding. Next slide. Autonomy. And we could debate philosophically about whether there is such a thing as actual autonomy, but for the argument's sake, let's take what this is described as. It's described as the right of the individual to make their own decisions without coercion and to exert self-determination. It's also the basis for requirements of the decision makers. So reflecting autonomy is kind of where we come to the point of defining what is informed consent, for example. When we are thinking about informed consent, especially in the medical context, the decision maker has to meet some criteria. The decision maker needs to be competent, not competent globally, but at least to make the decision that's applicable. They need to be told the truth. The burden of that is on the person telling the truth. They need to be fully informed, not just the truth, but everything that makes sense for them to know in making this decision. The person themselves has to be able to comprehend the information. They should be able to act voluntarily. And it's expected that their decisions, whatever they might be, meeting all that criteria, should be respected. Next slide, please. What about beneficence? How does that become a reality? It means promoting good for or doing good for others. It requires acting with kindness and charity. It means acting in the person's best interest and promoting their well-being. And as it applies to healthcare, it includes a commitment to relieving suffering. Next slide, please. Non-maleficence. In medical jargon, it's usually translated as first, do no harm. Refers to a duty to avoid causing harm to the individual or potentially others. Carefully weighing potentially negative outcomes against the benefits of an action that is being contemplated. Next slide. In this setting, we have to think about, as we are considering making decisions for other people, something called substituted judgment. And some people are a little bit confused about this, and it's important to understand it because it is the standard for deciding for others. It doesn't mean instead of the person about whom the decision is being made, it doesn't mean that the person making the decision makes their best judgment about what that person should have. It means that the person who is the decision maker has to make a choice on behalf of the incapacitated person, but the decision should be based on what the individual would have decided if they were able. So it's the challenge of putting the decision maker has to put themselves in the place of the other individual and how what we know about that person help us to know what decision they would have arrived at. Ideally, it's based on, therefore, on knowledge of that person, what their thoughts and their values are, and how the incapacitated person made decisions in the past is an important consideration. Next case. Next slide, rather. All right, take a breath because that's a lot of information. There's something else that is particularly applicable in wrestling with decisions sometimes in dementia, and it's called the principle of double effect. Unfortunately, many decisions we're required to make have good aspects to them and bad aspects to them. And that's a big source of why these decisions are so difficult. So the principle of double effect can be useful as it presents a set of ethical criteria for evaluating actions that have both a good and a bad effect. It suggests that an action is permissible if, next slide. Nope. Thank you. The action itself is good. What you want to do is good, or at least neutral. The good effect does not cause the bad effect. The bad effect is not what is intended. The good effect is not produced by the bad effect. So you can't have a bad thing that somehow causes another good thing. There is a proportionately grave reason for permitting the bad effect. That is to say that the good effect is a much more important and bigger effect than the bad effect would be. Next slide, please. Justice is almost always listed in the list of bioethical principles that are applied in healthcare decision-making or in deciding for others. But I'm not going to talk a lot about justice because this can be seen as different from different people's perspective. It's a general principle, and it states that healthcare justice refers to the fair and equitable distribution of healthcare resources, services, and benefits to all individuals, regardless of their socioeconomic status, race, gender, or any other personal characteristics. Next slide. Okay. So why are we having this talk today? There are many complicating, challenging, ethical issues in the course of the dementia journey. The care involves choices on a regular basis. So it's not like it's only at end of life, or there's a one-time thing where we're talking about something that's challenging and making decisions about dementia. It's happening. It happens regularly. And those who are caregivers know this. You just solve one dilemma and you're off to the next one, or you're dealing with the consequences of the previous solution to that dilemma, which makes for a stressful situation at times. Some have more serious consequences than others. That is to say, some issues have more serious consequences than others. But the sheer number of choices may be overwhelming. Not just how many choices I have for this particular dilemma, but dilemma after dilemma after dilemma. The principles, it's important to remember, do not dictate or make decisions. They have to be interpreted or acted upon by decision makers. But they can be helpful in being distanced and thoughtful about making decisions and less caught up in the emotional and personal needs that are associated with them. So let's consider how these principles that we've just reviewed and family dynamics may apply using examples of common, challenging ethical issues in dementia. Next slide, please. The setting in which these things occur is a setting where people with dementia often lack the self-awareness to recognize their impairment. It's part and parcel, unfortunately, of the disease. Denial of declining abilities and blaming others for accidents or mistakes is common. There can be a gradual shift in the individual's ability to be more engaged in modifying a situation. That is part of the solution to the problem or making changes that can alleviate the problem. The abilities may not be constant or consistent. So someone may be able to do something in some days and less able on other days. Gradually over time, often abilities tend to decline. But in the real time of one incident, it's hard to know. Family members and friends often must play a crucial role in observing behavior and eventually in confronting the individual to stop or change a practice for a variety of reasons, including some of the ones we're going to talk about in a minute. Next slide, please. One of the most contentious decisions that comes about often for many people in the dementia situation is restricting driving. Next slide. The contributing features to the issue of restricting driving have, there are a few of them, not just one. For one thing, driving for the individual often represents autonomy or personhood, like a definition, a key part of the definition of themselves as themselves. It represents independence. I can get up and I can go where I want to go, and I don't have to deal with anyone else making that possible. And trust or respect for the individual. It makes people feel less, not just less independent, but less trusted and less respected when they are told they can no longer drive. Driving also, however, involves a public trust. So yes, it's important. We have to consider the individual driver, but there's also a public trust in the safety of others, of both the person driving and the people not driving are very important to consider. Next slide. So here's an example. Mrs. R is a 76-year-old lady, and she has early dementia. Her son reports witnessing that she forgets where she's going when she's driving and becomes confused. She has had no accidents to date. When it's considered that suggested rather, that she stop driving, she refuses and becomes very upset. Sounds pretty common. Next case. Slide rather. So let's look at the situation. One approach to looking at these situations is first, identify the facts. Driving is impaired. Her ability to drive is impaired by observation of someone in the car at the time. And for her, driving does facilitate her independence and her quality of life because she can be involved in physical activities, in social activities, and intellectual activities by going places and doing things when she wants to do them. Then, now, are those things totally facts or are some of those opinion? Well, the way we would weigh the strength or the importance of those things certainly would be opinion. The family is weighing her safety heavily and not perhaps weighing her ability to get to places she wants to go and do the things she wants to do with the same weight. When does the responsibility shift and authority change? Well, there is a demonstrated problem, and there are differing opinions. That's when we start thinking about this. When there are concerns about judgment, that's when we start thinking about this. Is there a context in which shifting authority would be acceptable to the individual? So does the person with dementia at any point in the course of their disease have some thoughts about when and to whom they would consider sharing authority, or actually shifting it? And how is concern for both the individual and others balanced? Now, challenges with driving especially are that the patient, as we just mentioned a few slides ago, denies the problem. I can drive. There's nothing wrong with my driving. So we need to figure out a way that's going to try to appreciate the views of the individual and the needs of the individual for safety and the needs of the community. Next slide, please. Next slide. Yeah, thanks. When family conversations with the person are not working out well, or in fact causing additional distress, one can consider involving somebody else in the decision or the solution, or more importantly, in the process. The decision will still be made by the right people, the people who should make the decision, but a solution can be worked out perhaps by using the help of other people. Who might they be? They might be someone that this individual respects, someone who this individual does not feel threatened by, someone the individual doesn't feel has any reason to not be as supportive of their ideas as they would be of somebody else's ideas, so that there's, excuse me, perhaps a little bit more trust or authority if you go to a healthcare provider, perhaps. Consider more specific examination of abilities. If push comes to shove, particularly with driving, there are mechanisms for having people go through an examination to really tell what kind of abilities they have to drive. The Bureau of Motor Vehicles has mechanisms for this. Someone can actually make a report of a person whose driving skills are concerning. You do have to give your name. You have to be upfront about who you are and take ownership of that. But the Bureau of Motor Vehicles will act on that and suggest that the person come in and be evaluated. The evaluation is very straightforward. They do this all the time. There's a physician examination is for physical changes, neurologic changes that might preclude responses or reflexes and that sort of thing. But the Bureau of Motor Vehicles will actually walk the person through up the process of, can you do the tasks necessary to drive, including and up to and including a driving test with another professional in the car with them, which has been very helpful in many cases for both the potential the person who's potentially losing a driver's license and others, because they're very specific about this. And honestly, I've sent people for these tests, and they've come back with not their license taken away, but with restrictions that make sense to the people who are professionals in terms of what it takes to be a driver. For example, people will come back and say, I have to drive during daylight hours. I can't drive on highways. I have to drive on familiar streets, and I have to drive on regular streets, not highly trafficked ones. And then they have to have, people will get reports about how that's going. Next slide. So if we applied autonomy here to this case, that's respecting her self-determination and the beneficence, we're trying to support her quality of life and recognizing that that has a lot to do with her ability to drive at this juncture, and try to figure out what it is about that that's the most important to her so that we can address that. And not harming her, which would be a problem if she weren't allowed to have her some of her activities. That would harm her quality of life, which actually is important in terms of dementia. When we go and talk to people about what's good for brain health, well, it's the things that people often will go and drive their car to get to. Physical exercise, social interactions, intellectual exercise, a good nutrition. Often people living alone, when they eat their best, they're eating with other people. So we don't want to negatively impact on independence or the sense of self if at all possible. But again, we don't want to cause potential harm to the person themselves or to others. That's for sure. Next slide. So can there be a compromise? Can we facilitate what is most important within the realm of what is possible? Would supervised driving be helpful? Would alternate transportation arrangements work? The case when I first presented the case, it was brought about by her son, who witnessed her driving by sitting in the car with her. And as he drives with her, up until this case was brought forward, he would give her cues and say, "Mom, this is happening. Wait, there's a red light coming. This is that." Whatever is happening, reinforcing for her what she should do, and she was able to follow directions. So if that's workable, if that could be made available to her, could she still have some of the things that she really finds very valuable? Could that compromise be a possibility? And alternate transportation arrangements, I'm actually amazed at what JFSA does to assist with some of those things. Those can be challenging, but they may not be impossible. And at times people can't get everything they want, but they can get some things that they want, and that can be very important. If needed to protect her and others, again, that formal evaluation by a healthcare provider and/or the Bureau of Motor Vehicles can be very important. And when necessary, that's what you have to do. Next slide, please. Okay, what about managing financial affairs? Next slide. Mr. N is a widower living with early stage dementia, and his daughter is her primary caregiver. His primary caregiver, sorry. Despite declining memory, Mr. N insists on managing his own finances. He has a history of being very good at this. He was a financial wizard, but no longer able to do the same things. He becomes irritable and stingy about necessary expensive, like hearing aids, because they're too expensive, although his hearing is significantly impaired. And he has the money to do it. Yet he's making impulsive and odd purchases that make no sense to the family, and he can't really justify, which is very much unlike his previous thinking. Next slide, please. He has had some experience in thinking things through in advance. He has a durable power of attorney for healthcare, but no durable power of attorney for financial matters. To make things more serious, the bank repeatedly contacts his daughter about questionable transactions concerning and his concern for long-term financial security risks. The daughter knows that if she were to ask him to sign over financial authority, he would be furious and refuse. Next slide, please. What might our approach be here? Well, what are the facts? The facts do support significant change in decision-making, as appears to be corroborated by outside sources like the banker. He is acting in a way that is inconsistent with his previous character. So if we're thinking about respecting who he is in making decisions, this is not what's happening. Considering autonomy, which is what I just described, is he making decisions that are consistent with who he has always been in terms of his decision-making prior to his suffering from dementia? No. So we have to think about that. What would be the right thing to do for his good? What would be the beneficent benefit of the thing to do that would be consistent with beneficence? And non-maleficence, how can we avoid harm to him by having his finances in disruption? In addition, he's at risk for, it sounds like he's putting himself, not intentionally, of course, at risk um, for fraud, perhaps, since he doesn't seem to have a good understanding of what's going on financially, or to be put at financial risk by others. So when does responsibility shift and authority change? We do have a demonstrated problem, the financial risk and the potential risk to his independence if he can't afford things anymore, and independence if he can't hear, or simple things that might help his functional state. There are clearly judgment concerns, as we talked about. And the question is there a context in which shifting authority would be acceptable? When can we say he cannot make decisions about his finances, and how do we go about that? Next slide, please. Again, at some point, it's important to consider involving someone else in the decision or the solution. Could Mr. N have input in this? Could he get to a point where he could listen enough to participate in choice of a surrogate or a power of attorney? Would he understand there's a risk to a lot of people, unfortunately, these days, who are financially abused and taken by scams and whatnot, and just addressing in a way that he could understand. Maybe it's time for you to have, or maybe it would be a good idea for you to have somebody else who could be backing you up in all these decisions and supporting the right decisions for you to protect your investments and your money. Whatever language would be resonant with him and what he has always held important. More specific examination of his abilities, recognizing, as was true with the driving, that these may change over time. So whatever the abilities are now, they're not likely to get better, but could possibly get worse. And arrange for formal evaluation by a medical provider. If you think he has he's no longer competent, no longer able to make decisions, period, that's a very serious situation. And it would be important to have input as to what his abilities truly are at this point, and periodically, perhaps over the time in the future. Next slide. So we would want to ask questions about his concept of his situation. What does he think is going on? Respecting him and his thoughts on it, and non-threatening, and identify whom he might trust at some point. If he knows he has dementia, if he knows he has a progressive problem, at some point he might understand that at some point his abilities may necessitate some assistance, and here's his opportunity to make some input as to whom that might be. Is there concern for any other motivations in the case? Always important to do this, especially in dementia, where people really lose some ability to protect themselves, for anybody else who might be trying to get something that they really shouldn't have a right to have. Next slide, please. Okay. So what might next steps be? Well, in this case, in general, incompetency declaration can be avoided if alternative solutions are available. So he doesn't seem to be globally incompetent, so it would be important to explore any other solutions that might be helpful. He is at risk, as we said, for fraud and exploitation. So we could evaluate him for what protections and alerts he might allow. So what would be protections? Well, this certain amount would require another signature or somebody else to know about it. alerts if something like this happens in your account. Maybe we should have somebody at the bank notify somebody else, so your daughter or somebody, your son, whoever. Who would you want to trust and make those things a part of the routine of your how things work with you in financial areas? At the same time, we would want to think about, is there any other area in his life where things are getting a little bit uh, out of control? Investigate arranging for limited, perhaps, or surrogate financial authority. Um, if you can at some points get to a guardian or a conservator, but that's pretty dramatic, particularly guardian, because guardian really does take away a lot of rights. Next slide, please. Okay, so we're going to shift gears a little bit, talk briefly about advanced care planning. Um, this is particularly around healthcare. Next slide, please. So what do we mean by advanced care planning? You probably know well. A process that involves individuals reflecting on, and this is an important part we don't always put in the list, but reflecting on, discussing, and documenting their preferences and their values regarding future healthcare decisions, particularly when they may be unable to make these decisions for themselves in the future. There's a big, this sentence is fraught with its truth, but there are lots of, oh my, what does this even mean? Um, how do you decide what you would think about in the future if you were in a certain sense that you're not in now? That is a challenge, no question about it. How do we anticipate how we're going to think about those things? But if we look at the options we have available to us to support good decision making, this seems to make the most sense. To at least acknowledge by discussing, and even better, by discussing and documenting preferences and values. What is most important to an individual? What do they value greatly? And what does that mean in terms of potential treatments or situations they might be in? What would they be willing to have other people do to help them preserve their preferences and values? This is particularly important when the time may come when they may be unable to make these decisions for themselves, and someone else will have to make those decisions. If someone else is going to make a decision for you, you might as well tell them what you would want. That is how we preserve autonomy. Typically involves discussing personal values and goals for healthcare, which are things that not everybody is attuned to. Not everybody can even articulate without some assistance, and even then are challenged. Identifying potential healthcare scenarios and the corresponding decisions individuals would prefer or might arise in those contexts. Now, we can't anticipate every healthcare scenario, but common ones are common, end of life being one of them. And if we know a person's medical story, what their other maladies might be, we can make some judgments about what might be likely to happen, not knowing exactly what would. And in terms of thinking about this, the whole concept of advanced care planning really is rooted in respecting individuals and respecting people's choices. So we want to make sure that we get an understanding while we can, because at some point we likely will not be able to. It's also a huge burden to the decision maker at that time, the surrogate decision maker, if they don't have the ability or the tools to do that substituted judgment thing that I talked about before. Then they're left to do what they think is best, what they want. Very complicated. But people, so it's if people can, appointing a healthcare agent or surrogate decision maker can be really a useful thing. Completing legal documents such as living wills or medical powers of attorney forms are not, they're challenging just because of the content and the subject matter, and they are legal documents, but they don't require attorneys. Not that attorneys are bad or shouldn't be involved in things, but they're not required. It is helpful to have some kind of a professional share what it really means and what it means to the individual given their context and situation. And a clinician can do that. Clinicians are required if the person decides that part of their future care that they want to make sure is documented and enforced at the time it's needed as a do not resuscitate order, which is actually an order as opposed to an opinion. And that actually has to be signed by an appropriate clinician. And is something that occurs not just in hospitals, although it does there, and not just in nursing homes, although it does there, but even in the home. If somebody's called to the home of a person who has a do not resuscitate order and finds them in a situation where that would be applicable, they can obey that order in the home. Next slide, please. So here's a case. Mr. T is an 89-year-old man with a several-year history of Alzheimer's type dementia. He's no longer driving. He's still living alone in a duplex. His brother lives upstairs. His children are out of town, but they're involved. And over the last year, he's had increasing frailty. And the question comes up, should advanced care planning be addressed? Next slide, please. Well, what are the facts of this situation? Well, at some point, healthcare or end-of-life decisions are going to be needed. And the other facts that we may not, do we have the other facts that we would need if that happened? What do we know about Mr. T's wishes? What do we know about them now? What do we know about if we don't know what they are right now, do we know what they've been in the past? Did he ever make decisions for other people? How did he do that? And what were his thoughts expressed at that time? What was important to him as he went through that process? Next slide. When does responsibility shift and authority change? Well, in this context of progressive dementia, we can anticipate further changes and needs. How can we anticipate them? We can't, and we know they'll happen. We don't know when, we don't know how, we don't know in what order. Physical changes, medical diagnoses, progressing of the dementia. But we know that there will be further changes and increased needs. Judgment is likely to be of concern in the future. Ability to take medications. Are there safety concerns? These are all things we should consider as things mount up in terms of his losing abilities and living fairly independently. Is there a context in which shifting authority would be acceptable? And that, at this juncture, it seems like we could talk to him about that. What would he think about that? How would he feel about shifting responsibility, and what authority can we support for him to exert over that, and to whom? Especially the to whom. Who does he trust? Who knows him the best in order to do that substituted judgment for him? These are key things to have a handle on. And we've already got a scenario that tells us that this is going to be needed in the future. Next slide, please. So once again, we should consider involving somebody else in the decision or the solution to this concern. Does he need to be evaluated? If he were verbally able to sit down and answer questions like this, seemingly to understand questions like this in terms of whom would you trust to make decisions for you? Have you ever made decisions for somebody else when they were seriously ill? What were they? What was that about? If he could tell you those things, those would be important things to have. Does he need an evaluation to say whether he's capable of making some of those decisions? Um, I think it would depend on how we feel he is at expressing himself. It doesn't need to have a particular intellectual capacity in order to answer these questions. It's more about, I care about this and I trust in that. An evaluation is certainly reasonable, um, not necessarily needed for an advanced care planning situation, unless somebody might question it after the fact, like a sibling or another child or something. Consider more specific examination of his abilities then, and understand that those abilities still may change, but they're not likely to get tremendously better. And why I would suggest that advanced care planning should be something we would consider for this man and really explore the possibility of is because in these conditions, delayed action may very easily turn into a lost opportunity. So I have so many times been in the situation where nobody seemed to know anything about what this individual would have wanted, but there had been ample opportunity to have that conversation or to have enough of a meaningful discussion to be able to say, I believe I have good reason to think this is what my dad would have wanted. Next slide, please. That looks very similar to the last slide. Okay. No, that's okay. Go back. It's all right. Um, so pursuing formal advance directives um, is is very reasonable. Now, what does that mean? That can be a living will, a durable power of attorney for healthcare. Living wills are more specific about care at end of life, and durable powers of attorney for healthcare are specifically about telling who you want to make decisions on your part. And you can put, there's actually a hierarchy of order of people if you want to do that. In the absence of that document, clinicians will go to a hierarchy that's dictated by the law. So another thing to think about is whatever people's family situation is, we no longer live in the Ozzie and Harriet situation where it was clear, you know, what a family structure was and who was responsible for whom. So it's important to consider anything that's unique, or even if there isn't, what a person's specific preferences are in this regard. The law would say first you go to, for an adult, if you can't speak to the person, you go to the spouse. If you have children, if adult children, it's the majority of the children, not the oldest child, but the majority. So if you have 5 children, it's 3 out of the 5 that can be reached in a reasonable way to make decisions. If you have 10 kids, I guess it's 6. I can't say that I've had experience with 10 kids, but um, it can be very cumbersome, as you can see. Um, and then the list goes on in terms of whom we would consult in order to make decisions. So individuals should think about for themselves who's important to be at the table to make decisions, and how that would go if they don't make the effort to put that in documentation. Next slide, please. Okay. Choices about feeding. The picture here is actually a pretty common scene for a lot of reasons. Folks who are dealing with dementia, particularly later stages, uh, are not interested in eating, and it becomes a challenge for their nutrition, and that presents challenges for their health in general. Next slide, please. Weight loss and lower calorie intake are expected as dementia progresses. It's just what happens. Causes can include loss of appetite, loss of hunger, loss of thirst, loss of memory. I don't remember not eating. I don't remember if this is what time of day it is, and it's now 2 o'clock in the afternoon. I haven't had breakfast, but I don't remember that. Depression, social deficits. So one of the things that triggers people to eat is we sit down for breakfast, we sit down for lunch, we sit down for dinner in context of others. That may not be the case. Overall weakness and fatigue, particularly if you have to make their own food or get their own food, or problems swallowing are very common. It's often part of the disease. But things like dehydration can also impact that. Problems swallowing and eating may become uncomfortable. Patients may become distracted. They were sitting down and eating, and then they just lost track of what they were doing. And so they didn't finish their dinner or their supper or whatever. Most common cause of death in dementia is called aspiration pneumonia, which is a pneumonia or lung infection due to food or fluid getting into the lungs. So not going down to the stomach via the esophagus, but going to the lungs via the trachea. So swallowing becomes a big deal in this scenario. Next slide, please. The guidelines for patients with advanced dementia recommend, and who have trouble eating, recommend careful hand feeding, which is actually described in terms of a process, specific recommendations in most cases. Attempts at hand feeding, however, should stop if patients experience choking or gagging with assisted oral feeding, and strategies for comfort then should be employed. Next slide. A Cochrane Review, which is a well-known organization that reviews under a topic, they'll review all the literature and all the research available on that topic and then come up with a summary of that. And actually twice, the most recent one was in 2021, they reviewed the use of feeding tubes in dementia. And they did not find evidence that tube feeding improves survival, or it improves quality of life, or reduces pain, or reduces mortality, or decreases behavioral and psychological symptoms of dementia, or that it leads to better nutrition, or improves family or caregiver outcomes. So do feeding tubes ever improve in those circumstances? We can't say in any individual that there isn't some benefit to something. But if you look at the review of literature, and to be fair, there's not a lot you can imagine what kind of a study would you construct that randomized people to feeding tubes and not, which is the sort of the standard criteria for a study being a good study that you can rely on the results of. Obviously, that's not something that's going to happen. On the other hand, a lot of people have had feeding tubes, and there was not any ability in putting all those studies together to say that tube feeding did have these benefits. Next slide, please. So what do we want to think about in terms of choices about feeding in this case, in the case of dementia, where this is such a common thing late stage in the disease? Remember that advance directives can communicate feeding decisions, that the Ohio Living Will has a specific section related to feeding tubes. Um, and in fact, when one signs um, the form that you do not want to feed, you have to actually initial it to make sure that it's clear that that's what you want. It's important to communicate an advance directive and whatever the advance directive is, it's important to communicate that and its contents to key family members and certainly to decision makers. So, someone who goes to their attorney or goes to their healthcare provider or does whatever they do, and they go online and get the documents and sign them and have them witnessed, and then they put them in a drawer, that is not helpful. It's somewhat helpful to have them on file at your doctor's office or in your um, health, whatever system provides your health care. But the fact that it exists is one thing. The fact that it is communicated is a better thing. Um, so if I have a patient or somebody who has an advance directive, I want to talk to them about it. I want to know what that means to them. And then my notes will reflect my interpretation of what they told me. The same is true of key family members. Having an advance directive that you don't tell the people who will be making those decisions what that really means to you, you're not really getting the point of informed decision making. So it's important to both, and if the person is a key family member but not the decision maker, those are also important times to have both those groups of people be familiar with what you want. Okay, next slide. So, characteristics of dementia may lead to a myriad of personally, medically, ethically, and emotionally challenging situations requiring decisions and ethical assessment. Recognizing the complexity and thoughtful processing is key to making optimal choices. Next slide. We can, to some extent, anticipate potential issues and decision making and decisions, and doing that can be very helpful. Discussion and planning won't solve all problems, but it sure can help. Understanding the wishes of a person with dementia is critical to making the best decision. Ethical principles may support thinking through a decision, but it doesn't make the decision for us. While perfection is not usually an option, when a difficult decision must be made, caring and informed and thoughtful decision making is likely the best strategy. Next slide, please. Oh, don't worry, don't panic. I'm not going to read this. This is just an illustration in terms of the living will. This is the kind of verbiage that's there in order for people to sign to withhold treatment, withdraw consent to provision of artificially, technologically supplied nutrition or hydration. Um, don't be off put by that if that's what you want, just because it's in legalese, so to speak. Don't be off put by it. It's just the way it happens to be that's documented. Okay. Do we have time for any questions? Courtney?
Yeah, I'm here. Sorry, it was
Sorry,
sticking.
thought I got lost.
Yes, we do have a few questions. Let me hold on one second. Okay, so the first question, someone said, I would like to have a video camera in my parents' home to ensure that they're safe. They've each had a few falls. My dad says it's okay. My mom says no. Is it unethical if we place a camera and not tell our mom?
Hmm. Hmm. Can your mom articulate a reason not to, is the question. What is she afraid of? I think I'm sure you've asked that question, whoever asked this question. But I would explore what she's afraid of about that, if possible. You could even say, I'm really worried about dad, because you are. Um, and she might get behind that posture. The other thing to consider is what do you suppose she's afraid of? Um, is there something, is she afraid that you're going to find something that you might be concerned enough about that she'd have to move, or I'm just, I don't have any ideas, but that what it might be. But there's some reason that she's saying that. And I wonder if there's any way to get closer on that. But you're right, it's not ethical. Do we do unethical things? You remember that double effect I mentioned? Sometimes we do things that we otherwise would consider not good, but we're doing something that we think is especially good and really needs to happen for a really good reason. And unfortunately, by doing that, something we would think is bad is also going to happen, but uh, it is justified in that context.
Okay. The next question, how to best approach the conversation about dementia with someone who is not able to accept that they have dementia. I don't want to pretend that my husband doesn't have it, but I don't want to keep upsetting him by bringing up his dementia.
Hmm. Yeah. That's a terribly difficult situation for everybody, both the person who doesn't want to hear it and the person who doesn't want to say it but feels the need to say it. If there's other language you can use, um, you can try a provider or a specialist in dementia to see if they can explore it with you. What other language you can use? It's a physical illness. It's not, I mean, what is his interpretation of what dementia means or um, some people think it's a weakness. Some people think, they feel mental health problems are weaknesses. They're not, but they're actual diseases. They're actually problems that people have in their physical being. Would you consider a stroke in the same way you consider dementia? Would you consider a heart attack the same way in which you consider dementia? They're all medical problems that we have to work on together and see if we can take care of them together. The stigma associated is a real problem. But if you can get somebody else maybe to help work through that with them, that might be worth a shot.
Okay, and the last question has to do with advanced directives. If a
Hmm.
person with dementia keeps changing their minds about advanced directives, should you keep going back and forth, or should you do your best to encourage them to stay with the original plans? For example, if someone wants to be a DNR and then later, when their dementia has progressed a bit, they change their mind.
I would, well, the problem is as dementia continues to progress, their ability to justify what they're saying is also a problem. So they may say, if you keep asking them the same question, you may get different answers, but you're not going to be able to get the why. Excuse me, which is a big challenge because the decision is critical and we're going to act on the decision, but we do so because we trust that the why is there. And if the person is unable to articulate the why, and they could articulate the why initially, and the why hasn't changed, what I would think about, well, if I were the decision maker without knowledge of this, what would I think? But with knowledge of this individual, um, I think I would explore possibly continuing what they said before if they were really of their right ability to make decisions at the time, and really wonder how if they could possibly tell us why they're saying something different now, particularly if it went from DNR to not DNR. If it went from not DNR to DNR, it's interesting, but I think we would probably take that because they're seeing something worse and they don't want to, that sort of has some hidden logic to it. But if they went from DNR to no DNR or to not DNR, whatever it was, not DNR to not DNR, um, what is their thing? Are they actually cognizant enough of the fact to be worried about dying and what that would be like and what happens and that kind of thing? And if there's a possibility of working that through with them, and that would be worth trying too. And whether that would be if they're religious with a religious person who we might strike a chord with, or with a provider who might be well versed in having that conversation. The person who asked the question, I would also get some support for you because it sounds like that's really a tough situation and probably just the tip of the iceberg in terms of other decisions that are going on.
Okay, thank you. Um, Again, you can contact myself, Cassie, or Hannah with concerns about dementia and memory loss. We can talk about referrals and we can discuss our program and how we can best help you. These are our dementia specialists that we work with, Dr. O'Toole, our presenter, our geriatric psychologist, Dr. Orlasky, and Pamela Lynch does our caregiving with confidence workshops several times a year. Our next one will be starting in January. Some additional resources, our Caregiving with Confidence workshops, our dementia support group. 3 times a month we meet on Zoom. The next one is going to be next Tuesday at 1:30. Our Alzheimer's disease and dementia support program, our supportive home care program with respite care, these brain health and wellness initiative series, our memory cafe, which we do twice a month and will likely be moving to every week in January, and the Medicare CMS Guide Dementia Care Program. Our next brain health is going to be Are There Drugs to Prevent Dementia? Our presenter will be Dr. Grossman, and we're going to be doing it a week earlier next month due to Thanksgiving, so it will be November 13th at 6:30. This is a contact information to reach myself, Cassie, or Hannah. Thank you all so much for attending.
Thank you.
Thanks, Dr. O'Toole.